Thank you. So, hi everyone. My name is Aziza Merzouki. I'm a postdoctoral researcher at the Institute of Global Health at the University of Geneva. And in collaboration with the Terre Foundation and with the support of the Cloudera Foundation, we work at improving the quality of healthcare in Burkina Faso for children under 5. And we focus on detecting and addressing the diagnostic mistakes done by frontline healthcare workers using machine learning techniques. So our work is based on a program called Leda, developed by Terre. Leda stands for Integrated E-Diagnostic Approach. And as my colleague Marussia Rollens presented it earlier this afternoon for another project, Leda is based on the IMCI protocol developed by WHO and UNICEF in 1995 in order to reduce the morbidity and the mortality of children under 5 in low and income and middle income countries like Burkina Faso, where still one child over 10 dies before the age of 5. So the Leda program developed an application running on mobile or on Android tablets, which supports the diagnostic of children under 5 by assessing some danger signs, symptoms, helping the frontline healthcare worker to classify the degree of severity of the condition of the child and to recommend the prescription of a treatment. So, as a reminder, the Leda program is now deployed in more than 60% of primary healthcare centers in Burkina Faso. It is used by more than 5,000 frontline healthcare workers. 2.5 million patients are registered, and it allowed to collect a huge amount of data, 5 million consultations data. It's now also being deployed in Mali within 40 healthcare facilities. So with this huge amount of consultation records, we have identified several goals with our partners, and one of them is trying to reduce the human errors made by frontline healthcare workers during the consultations in order to prevent misdiagnosis of children and trying to improve the quality of the healthcare for them. So, in order to start, we initially do not have any external information. So if we want to identify errors or specific behaviors that may be erroneous done by frontline healthcare workers, what we can start with is an outlier analysis made on these consultations. So we start by assigning an anomaly score to each consultation using an isolation forest algorithm. And what you see on this figure is a projection of a sample of all the consultations of 2018. And these each consultation is represented by a data point, which is colored based on its anomaly score. So in blue, you see 0.3% of the consultations with the higher anomaly score. So this is for visualization and interpretation purposes that we use this projection using principal component analysis. But this doesn't say much, actually, because one of these blue dots may represent like data that were wrong data that were entered by a frontline healthcare worker, but it can also represent a real patient with excessively high weight and height, for instance. And this shouldn't be identified as something wrong done by the frontline healthcare workers that could be improved and addressed by our model. So that's why we actually looked at the distribution of the anomaly scores of consultations of all the consultations of each agent. So these distributions are represented here by these violin plots that you see colored either in blue or in red. And the colors that we have chosen for this distribution actually are because we clearly see by eye that they represent like different types of behaviors of the frontline healthcare workers. So in red, what we see is agents with most of their consultations are quite typical consultations, which are really similar to the majority of the consultations that we see in our data set. In contrast, the blue agents, there we see that they have a majority of consultations which are in reality really rare in our overall data set. So this may trigger some doubts about the behavior of these agents. But in order to interpret and to try to characterize the behaviors of these different types of agents, what we have to do is to go back to the original data that we have used in order to represent what is a consultation. In our case, we used some anthropometric measures, such as the height, the age, the middle upper arm circumference of a child, his age, but also some vital signs, such as his temperature or his respiratory frequency. So if we look at the distribution of these original variables for the different groups of healthcare workers, what we see is the following. For instance, the blue agents tended to report higher numbers of children with low height for age, so which are quite small for their age. At the same time, they also reported higher numbers of children with high weight for height, which means that they are quite heavy for their height. If we consider these two observations at the same time, what it suggests is that these agents may have underestimated the height of the child. This is not insignificant because these kinds of metrics are used in order to diagnose severe acute malnutrition, which is known to increase the mortality of children. And it's quite unfortunate because if it's well diagnosed, it can be reduced significantly and substantially with a proper therapeutic diet. But there is a warning sign. An outlier, either for a consultation or for a frontline healthcare worker, doesn't necessarily mean that they are doing something wrong or that the data that were entered during this consultation have something erroneous in them. For instance, if we look at the distribution of the respiratory frequency, we clearly see two nice peaks at 40 and 50 breaths per minute. If you know IMCI protocol, and if you just talk with experts, you know that these are exactly the values of frequency of respiratory frequencies above which a pneumonia diagnosis is given and where antibiotics are prescribed. So if an agent wants to prescribe antibiotics to a child in order to make the mother happy or what else, he just have to enter the right respiratory frequency. But sometimes it's not always cheating against the app. It may be really some difficult tasks that, for instance, for diagnosing anemia, it's mainly based on the color of the child's palm, the pallor of the palm. And it's something which is quite difficult. So we see that for a majority of healthcare workers, there is an underdiagnosis of anemia. And this doesn't mean that it's something good and that outliers, in this case, are doing something wrong. So these kinds of models and results can be used directly during the consultations in order to raise an alert. Please verify your input for height, or please verify the value that you have entered from respiratory frequency. We are quite lucky as well, because we know that frontline healthcare workers are really keen to receive a feedback on their usage of the app. There was a study that has been performed last year, which showed that they want to get feedback on their usage, and they want to have a comparison of the way they are doing compared to their other colleagues. So we can use this opportunity in order to tell them, okay, you may have overprescribed antibiotic last week. Please, we recommend you to have a look at some online courses which are available. Or you may have entered incorrect heights for children, or you may have done some errors measuring the heights of these children, and provide some rewards in order to let them compare themselves to their colleagues through, for instance, bronze, silver, and gold medals. We also got a really strong and positive feedback from managers, facility managers, and district managers, which wanted to have also reports on aggregated data in order to be able to recommend targeted training and coaching sessions on site, for instance, for their frontline healthcare workers. So, in summary, the Leda, through the digitalization of the IMCI protocol, is a great source of consultation data in Burkina Faso, using machine learning such as an outlier study, or being able to visualize these data and give an insight on these data allows us to identify different groups of frontline healthcare workers with specific behaviors that we can afterward address either during the consultation or through regular reports to the agents themselves or to their managers. And we have to keep in mind that we should always keep the human expertise and the experts on the field in the loop, either during the development of the models, during the interpretation of our results, and when we give the feedback to the agents, because, as you saw, an outlier doesn't always mean that it's an anomaly or an erroneous result. Thank you very much. So, do you have questions?
Just a quick question.
Yeah.
Can you see malnourishment, like physically, in such an environment?
Sorry?
Like malnourished child in a doctor in Burkina Faso. Can the doctor see that the kid is malnourished?
I'm sorry.
Yeah.
Oh, how do we measure malnutrition? Through these weight for height. So there are actually some metrics used by WHO in order to diagnose either severe acute malnutrition, severe chronic malnutrition, based on these Z scores, how much the measures of weight for height, weight for age, and height for age are being different from the median, as well as the actually middle upper arm circumference. I can.